It's not going to change the toughness in the tissues in your knees, your hips, your spine. It's not going to train you to have the visual input about where the ball is and how to adjust the position of your foot, how to trap the ball so that you don't knock it too far away from you. So when you think about the neurologic remodeling, about the overall remodeling that is involved in a motor skill, it takes longer. So we're starting with this. And it's, of course, what excites us. How many people know who Carla Stecco is? Yeah. The Steccos are a family in Italy. The dad is a PT. He's got at least 2 kids that we know of. One is named Antonio, and he's a physiatrist. And Michael and I and Tina took a course from him at UC San Francisco, brought over by Chris DiPrato. You know, Chris is very much interested in the fascia. And his sister, Carla, is a surgeon. And she has produced a book that is just unbelievable as far as enlightening us about the connective tissue and about tying the information with the connective tissue to clinical practice. I've read it twice. I read it the first time, and then I read it the second time, making detailed notes. Again, I understand the thought about learning and the need for repetition. I think that you'll see that it is really worthwhile. And we are going to look at some of her videos. Okay. So this is going to be about the loose connective tissue. Let me see if I got this turned on. If this needs to be, no. Come on. I need to, okay, hold on. I got to turn up the volume on this and on the TV. Okay, that is up. Okay, let's see if that is going to do it. Okay.
We can mobilize the muscle laterally without difficulties.
Okay, I'm going to start over here.
Presence of abundant loose connective tissue.
Okay, so when you're looking at the video, then notice what you're talking about, but I want you to notice how the connective tissue deforms when her hand interfaces with it. So not just, in this case, the loose connective tissue between the pec and the underlying tissue, but notice how the pec itself deforms. And so, you know, she's doing this on fresh cadavers. If we only looked at embalmed cadavers, you have a totally different image about the pliability that should be available in the connective tissue.
The loose connective tissue. After having detached the pectoralis major muscle from its sternal and costal insertions, we can mobilize the muscle laterally without difficulties, thanks to the presence of abundant loose connective tissue that creates a plane of gliding between the pectoralis major fascia and the clavipectoral fascia. Note the completely different structure of the loose connective tissue with respect to an epimysial or aponeurotic fascia. Indeed, it has a shapeless form, and the thin fibers are disarranged. In the cadaver, the loose connective tissue is dehydrated, and consequently the fibrous components are more visible. Really, in the living, the glycosaminoglycans and the hyaluronic link many molecules of water, permitting the perfect gliding between the two fascial planes. In any case, only where the loose connective tissue is present can we separate the pectoralis major from the deeper planes using only the fingers, while where the muscle has a bony or fascial insertion, like here, this dissection is impossible.
Okay, can I show it one more time? So again, notice how it all deforms, how it all yields.
The loose connective tissue. After having detached the pectoralis major muscle from its sternal and costal insertions, we can mobilize the muscle laterally without difficulties, thanks to the presence of abundant loose connective tissue that creates a plane of gliding between the pectoralis major fascia and the clavipectoral fascia. Note the contributing structure of the loose connective tissue with respect to an epimysial or aponeurotic fascia. Indeed, it has a shapeless form, and the thin fibers are disarranged. In the cadaver, the loose connective tissue is dehydrated, and consequently the fibrous components are more visible. Really, in the living, the glycosaminoglycans and the hyaluronan link many molecules of water, permitting the perfect gliding between the two fascial planes. In any case, only where the loose connective tissue is present can we separate the pectoralis major from the deeper planes using only the fingers, while where the muscle has a bony or fascial insertion, like here, this dissection is impossible. Aponeurotic and epimysial fasciae. We have removed all the subcutaneous tissue of the anterior region of the arm to show the brachial fascia. We have cut the brachial fascia to show its features. It is a typical aponeurotic fascia. Indeed, it is a white, fibrous layer, very resistant to tensions. It could be easily detached from the underlying planes, thanks to the presence of the epimysial fascia of the biceps muscle and loose connective tissue. Note the strong resistance to traction and its fibrous aspect. Note how the epimysial fascia is completely different. It is adherent to the biceps brachii muscle and thinner. The fibrous aspect is less evident. Here we have cut also the epimysial fascia to show the biceps muscle.
Okay, I'm going to show it one more time. Notice that even with that aponeurotic fascia, how it dissipates forces, how it yields to the forces of her finger. Remember, it's going to be these layers of fibrous tissue.
And epimysial fasciae. We have removed all the subcutaneous tissue of the anterior region of the arm to show the brachial fascia. We have cut the brachial fascia to show its features. It is a typical aponeurotic fascia. Indeed, it is a white, fibrous layer, very resistant to tensions. It could be easily detached from the underlying planes, thanks to the presence of the epimysial fascia of the biceps muscle and loose connective tissue. Note the strong resistance to traction and its fibrous aspect. Note how the epimysial fascia is completely different. It is adherent to the biceps brachii muscle and thinner. The fibrous aspect is less evident. Here we have cut also the epimysial fascia to show the biceps muscle. movements of the arm stretch different portions of the pectoralis major fascia. In the cadaver, we have to analyze the muscles without their basal tone. You can see here the pectoralis major enveloped by its epimysial fascia. Note as also this fascia is unstretched because its basal tone is given by the myofascial expansions that insert into it. If we move passively the upper limb to simulate an abduction, we see that some muscular fiber bundles of the pectoralis major and the corresponding fascia are subject to tension. Also, the intramuscular septa are stretched and consequently are more visible. If we perform an intra-rotation movement, we stretch a completely different pattern of muscular fibers and pectoralis fascia. You can note also the movements of the clavicle and how the fascia of the sternocleidomastoid muscle is stretched. In this sequence, we can appreciate how each movement of the upper limb stretches a specific portion of the pectoralis major muscle and of its corresponding fascia. The passage between a position to another one needs the contraction of some muscular fiber bundles and the relaxation of others, but this variation is uniform, guaranteeing fluid movements.
Okay, so I'm going to show it again, and notice when she's moving how far the force impacts the connective tissue. And notice that when she gets into the combined movements, how far up into the neck, down in the thoracic cage, in the opposite pec, how the tissue has to yield. And so when you think about trying to restore motion in a shoulder, and you think about producing glides at the glenohumeral joint, it could be too shallow of a view. You've got to look at the distribution of mechanical forces way up and down the chain. So you need to have an understanding about the whole picture when it comes to the connective tissue and where we're going to be working.
How the movements of the arm stretch different portions of the pectoralis major fascia. In the cadaver, we have to analyze the muscles without their basal tone. You can see here the pectoralis major enveloped by its epimysial fascia. Note as also this fascia is unstretched because its basal tone is given by the myofascial expansions that insert into it. If we move passively the upper limb to simulate an abduction, we see that some muscular fiber bundles of the pectoralis major and the corresponding fascia are subject to tension. Also, the intramuscular septa are stretched and consequently are more visible. If we perform an intra-rotation movement, we stretch a completely different pattern of muscular fibers and pectoralis fascia. You can note also the movements of the clavicle and how the fascia of the sternocleidomastoid muscle is stretched. In this sequence, we can appreciate how each movement of the upper limb stretches a specific portion of the pectoralis major muscle and of its corresponding fascia. The passage between a position to another one needs the contraction of some muscular fiber bundles and the relaxation of others, but this variation is uniform, guaranteeing fluid movements.
Okay, so how are we going to sort it all out? That is going to be the question. Put this down there. Okay, so again, when we think about training our own nervous systems, I want you to have the thought that, that the goal of what we're going to do now is not that you learn a bunch of techniques from us, but that the whole idea is that you're going to work on the remodeling in your own nervous system. your ability to palpate things, to pick up tension, to pick up different characteristics of tissue that will be important to tell you what the presentation is. We know that you're, I don't know if this is true, but I was told that every moment our nervous systems are bombarded with 400 billion bits of sensory information. Sight, sound, taste, smell, touch, temperature, 400 billion. Our nervous systems can only make a conscious thought out of 2,000 of them. So you have all this sensory information that's just floating past us that we're totally unaware of, doesn't come to our consciousness. If you all thought about the sensation on your right big toe, then you're going to notice, yeah, there's sensation from my sock and my shoe. Totally unaware of it until you brought your attention there. And so when you are doing your palpation, then you need to calm your mind enough and block out other sensory input. Most of us are visually dominated. Whatever we're seeing is dominating the 2,000 bits of information that get taken in. So you'll notice that if you close your eyes, that you're going to be able to perceive more. When I am at a concert, I'm torn between closing my eyes because I hear better, I hear much more, and keep my eyes open and enjoying the visual part of the concert. You with me? It is because your nervous system can't do both. I do as much as I can with my eyes closed. Treating patients around the house. I try to find the plug to plug in the coffee in the morning without the lights on. I will admit we're on the straightaways running. I often close my eyes and feel the sensation of running, right? You sense so much more. And so when you are doing your palpation, then you're going to have to quiet your mind. If you got the conversation going on, if you got all this extra stimulus, then you're not causing the remodeling that's going to be important for the skills of your palpation. Okay. So palpation, passive movement testing, we're going to focus on these characteristics. One is the physical characteristics of the tissues. Two is going to be the grade of motion that is occurring and the size and the quality of the grade 1, grade 2 slack zone, grade 2 transition zone, where the first stop is, and what the feel is beyond the first stop. We're going to pay close attention to the axis of motion or the plane of resistance. And then we're going to, of course, pay attention to the relationship to symptoms. When you think about your palpation and passive movement testing, when you think about your palpation, then it can come down to these 5 things. The key indicators about the health or the dysfunction of the tissue and the type and magnitude of the dysfunction will be identifiable. You pay attention to the temperature, the density, the pliability, the mobility, and the elasticity of the tissue. So by giving you something defined to look at and to look for, we'll cut down the options. So it's going to be easier for you to get the hang of it. How many people were told in PT school, you won't feel anything for 5 years, just go out and start feeling, right? Right? I mean, come on, give me something, right? It'd be like if we're going to want to learn how to taste wine, say, okay, let's just all go and drink a bunch of wine. But if you have a coach that says, pay attention, can you detect the qualities of the wine, whatever that is, and then compare it to this one and see how it's different, then you can speed your learning. So to know what to look for, and I am not kidding you, between these 5 things, you can know everything you need to know about the quality of tissue and whether it's like the theoretic norm or the type and magnitude of dysfunction present. Okay? So the density, of course, is how thick it is, the amount of fibers per unit of space. The pliability is how easily it can deform without damage. The mobility is going to be how easily it moves in relationship to the tissue adjacent to it. And the elasticity is its ability to spring back once it's been deformed. Okay? So you're going to pay attention. Density, pliability, mobility, elasticity. It's going to tell you everything you need to know. Okay? And then we need to figure out, we need to touch enough 27-year-old healthy people that we know what the theoretic norm is going to be. So when it's different than that, it will jump out at us. Okay? The functional characteristics could be put this way. They will be reflected in the perceived ability of the tissue to yield to or dissipate forces and to resist and withstand forces. Okay? So again, back to the movement diagram. No matter what tissue you touch, what direction you touch it in, there should be ability of the tissue to yield. And there should be a characteristic slack zone where there's play in all directions, no resistance. A transition zone where there is the heaviness of the tissue, but you haven't pulled it taut yet. A first stop, and then the feel beyond the first stop, the in feel. Okay? In that process, again, I know you've all seen these movement diagrams, but have you really digested them? I mean, they're just so fantastic. If we look at the normal, so this grade 1 is going to be when you first touch the tissue, and theoretically you kind of negate the normal compressive forces between the joint, is going to be how easy it separates, how quickly it yields, how easily it yields, okay? And then the grade 2 slack zone is going to be that range that you're going to have where there is movement of the tissue, but nothing is pulled taut yet. And then there's going to be a little bit of heaviness, and then you're going to come to a point where there is an abrupt increase in the resistance, the first stop, and then there's going to be how it feels at the end. So if you look at a hypomobile tissue, it will be shorter, absolutely, hypomobile. But look at the very beginning. The grade 1, the very first touch. More resistance and less yield. More resistance, less yield. This grade 2 slack zone is going to be shorter. Transition zone, shorter. Greater ramping up of resistance. The amount of resistance after the first stop is going to be more abrupt. If you look at a tissue that has loss of structural integrity because of distended, weakened connective tissue, when you touch it, it's going to yield further with less resistance. The first touch is the first touch, the lightest touch. It should be evident if you're paying attention. Then the grade 2 slack zone is going to be longer, less resistance. Transition zone will be longer. The resistance is going to build more gradually. Hit the first stop is going to be distended, and the resistance that you get after the first stop will be less abrupt. But the key to the story is this. It is paying attention here. Paying attention here. If you can feel the yield of the tissue in the very beginning, it is going to tell you with pretty good accuracy what's going to happen beyond. So if you can get good at picking up the quality of that first touch and how large the slack zone is, then you can make pretty accurate determinations about the health or the type and magnitude of dysfunction without having to challenge the tissue. if you can make accurate interpretations without having to challenge the integrity of the tissue, how much information can you gather without threatening to make the patient sore? You with me? So even if they've got a sensitive situation, if you can pay attention to the beginning, then you can figure out what the type and magnitude of the presentation is and start an interface that is going to be appropriate for that tissue, for that patient, without threatening making the patient sore. If you touch the tissue and it's hypomobile in the beginning, so it's more dense, less pliable, less mobile, then you should be able to pick that up from the beginning. You don't need to take it to the end. We are driven to go to the end, but you want to pay attention to the beginning. Freddie Kaltenborn, the guy that started the Kaltenborn avian system in Norway, has several books out, and he has an advanced mobilization book. And I was putting together the examination for the Kaltenborn avian instructors. And so I was going through all of the books. And I've read them before, but it's interesting how you'll get exposed to something you've read or seen before, and the importance of it will jump out at you. And he made a statement. He said, when you're trying to increase the mobility of tissues, then your focus should be trying to increase, to normalize the grade 2 zone. So he wasn't saying, you go to the end and you force this baby. He says, you coax the tissue to make the grade 2 zone more like the theoretic norm, and everything else takes care of itself. So when you think about when you are finessing the tissues of your patients, instead of feeling you have to go to the end and apply force, is the slack zone as large as it should be? Is the transition zone where it should start, and is it the characteristics of the resistance that it should be? So when you think about that, you think about the finesse of your touch, of your mobilization, versus we've got to stretch this tight shoulder, we're going to apply mega force at the end range and pay no attention to what happened at the beginning or the mid range. Okay? Okay, so in that sense, we can have a quick screening if we look at the density, temperature, density, pliability, mobility, elasticity of the tissue. So let's do something physical. So I'm going to put this guy down. I'm going to have Emily come up here. Oh, let me just, one more quick demo. So again, you're going to say, as you touch the tissue, what's the quality of the tissue, and how much can it move so that there is no resistance, no drag? And then, when can I feel the heaviness of the tissue even though I know I haven't pulled it taut, the transition zone? And then where is that first stop? And then in your mind, can you say, the only two types of presentations that I'm going to treat beyond that first stop are dense adherent connective tissue, hypomobility due to dense adherent connective tissue, or interarticular lesion. Everything else I'm going to treat, whether it's desensitizing the nervous system, where it's neuromotor training, where it's addressing inflammation, where it's addressing increased muscle tone, they'll all be short of the first stop. So again, think of the finesse, okay? And then anything beyond that's going to stretch it. So when we are looking at the quality of tissue, if I were to slide this towel, there's no axis of motion. I can slide it in any direction. I can feel the firmness. If I just put this underneath, then the axis of motion changes. Or as Cornelia would say, the plane of resistance changes. Now, as I pull here, can you see how this doesn't deform as much? Because there's a little added resistance. So if you pay attention, I can feel the density of the tissue. Oh, I can feel it's changing. Oh, different density. Okay? But this mindset of if there is more drag or if there is less drag, if I cut the towel and I pulled on it, it would move easier. If I had altered structural integrity because of weakened, distended connective tissue, it would come apart easier. When I touched it, it would come apart easier. If it is because of dense adhered connective tissue, I can feel increased density, decreased pliability, decreased mobility, decreased elasticity. Okay? That's what you're going to be looking for. Okay? So if you guys need to move in order to see the demo of what you're going to do here, that would be great. Emily, I'm going to put you on your back.
Do you want to switch your dog?
Yep.
Okay. You want sweatpants off too?
Nope, not yet. Okay, so you're going to get used to paying attention to placing things in the slack zone. Because then you can pay extreme attention to what you're paying attention to and minimize the chance that there's going to be some irritation in her low back, in her old knee pathology, or something else. Okay, so this is what you're going to do first. You're going to pay attention to the temperature of the tissue. I'm going to back up. You're going to think about the key indicators for these other aspects of the presentation. So when you look at her, you're going to say, and what about her general health? She looks a little tired.
That's pretty accurate.
Right? You're going to say, okay, well, what about her central processing? What about her overall structure? What about her neuromotor function? You know, when she gets on off the table. You're just going to start to track these key indicators as you're going about paying attention to, in this case, the quality of the soft tissues. But if I can have an impact, it's going to be you're going to look at that, the appendix A and appendix B, and you're going to just see how simple it is. Oh yeah, I can pick those things up quickly. And you're going to make these judgments without having to spend a ton of time about their central processing and about their fluid exchange and about their voluntary behavior as you go. All right. Okay. So with Emily, even with this light touch, she has much more muscle tone here than she should. Okay? Yeah. So you're going to look at the density, the pliability, mobility, elasticity of the tissue. And because it's a comparative experience, you're going to have in your head what it would feel like on that healthy 27-year-old. But then you're going to have to feel the body next to you, and the body next to you, and the body next to you, and the body next to you. Because you've got to feel, it's got to be a comparative experience. When Ulaf would come, either Freddie or Ulaf came here for 27 years in a row. They would teach a 4-day course with us, spend time with us in the clinic, and at the end of every course, Ulaf would, say how nice it is to be back in Folsom and how he just enjoys being with therapists and he thinks they're such good people. And then he'd say, you want to take every opportunity to enhance your tactile vocabulary. And he would sit down at the table. I was usually the demonstration person. And he would take my hand and he'd say, if you're riding on the train, public transportation in Norway, then you'll spark up a conversation with the person next to you and eventually, grab their hand and feel the tissue and feel every opportunity. You with me? And I can feel that with Emily, she's got much more muscle tone than there should be. It is not it's not like the healthy 27-year-old. We're going to have to do something about this. Okay? All right.
From all the work I do.
All the work you do. Could be. Okay? And can you see how she keeps tightening her arm? Did you notice that? And so we know that her nervous system is running a little bit faster than it should. Her central processing, right? And her neuromotor control. But that neuromotor control would go along with the fact that her connective tissue is denser, less pliable, less mobile than it should be. We would think that because the tissue is denser than it should be, it's got to influence the circulation. And we know the key to health is perfusion. If the circulation's not good and the cells aren't getting nourished, things aren't going to be as good as they could be. So without knowing anything else about Emily, if I worked her soft tissue and made them more pliable, more mobile, less dense, I could help her. If I said, because she has a tendency to, hold muscle tone, if we worked on her ability to relax, I could help her. If she's got this presentation, then I would think that her proprioception is probably not quite as good as it should be, and therefore her neuromotor control is not quite as good as it should be. So, I don't know what will happen, but let's just see. If you make a fist and you hold this, hold here, see it, right? Even that, her ability to process the information, I don't mean to be pounding on you here.
Okay.
Right?
Yeah.
But can you see, I want her to hold against my resistance here, right? And it took her time to find it. So I did need a ton of examination time to say, oh, her proprioception is not quite what it should be. Her neuromotor planning is not what it should be. I can jump to conclusions. You with me? So hold here and hold here. Hold here. Hold here. Can you see how it takes her time to find it, time to adapt? You with me? If you had somebody that had a very clever neuromotor system, then she should well perceive this. And again, Emily wasn't bad, but there was a delay. So I'm going to say, okay, she's fitting the pattern. She's following that pathologic cascade, even though she's functioning normally. I really don't know too much about her health. I don't know if she has any musculoskeletal pain. But if she doesn't yet, she is more susceptible because things are not like the theoretic norm. So even if we just help these tissues be more like the theoretic norm, we could help her. So the first thing you're going to do is you're going to come up and you're going to assess general health, central processing. If they talk, you're going to say, what about their voluntary behavior? What about fluid exchange? Does it seem like she's holding fluid? Yeah. Does it, what about her muscle tone? What about the structure of her passive body structure? Can you just pause and say, what can I glean? And then you're going to do this superficial palpation and just see if you can pick up where the tissue is not like the theoretic norm. And because it's a comparative experience, it might mean nothing to you the first time you touch somebody. But I'll bet you $1 this is a little tender. She's going to be stoic. Okay? It's thicker than it should be. I'll bet you that this is tender because it's thicker than it should be. It's not as pliable, it's not as mobile as it should be. Okay? So you're going to do this quick screen, and then you're going to see if you can feel the difference in the layers of tissue. If I grabbed her here, I've got her skin, superficial fascia, and muscle. If I come here, I've got superficial fascia, muscle. And you can see how I'm really struggling to pick the superficial fascia up off of the underlying muscle. It shouldn't be this way. And then if I come here, I've got skin, yikes, skin over the superficial fascia. If we looked at an old guy, you know, as we get older, then the connective tissue loosens. But here I've got skin, superficial fascia, and muscle. Here, I've got superficial fascia, muscle. Look how mine comes up compared to Emily's. Here, I've got skin on the superficial fascia. If there's not movement between those layers, and if the quality of the tissue, the thickness of the tissue is not like the theoretic norm, then it's not like the theoretic norm. And if we can make it more like the theoretic norm, all the systems are going to be healthier. Okay? So that's what I want you to do first. I want you to, pair up. You're going to pair up. You're going to just size up the person's health. General health, central processing, fluid exchange, body structure, and just see how it looks. And then you're going to do this scanning palpation. Can you look? See how she can't relax? You see that? Right? Right? You have to think about it. Correct. Right? And so again, you just know that it's not what the desire would be. You with me? So you're going to take that in. You're going to do this screening palpation. Pay attention to temperature, density, pliability, mobility of the tissue. And then you're going to say, can I feel all the tissue? Can I separate the superficial fascia? Can I separate the skin from the superficial fascia? And if the patient that you're working on says, oh, that is tender there, then you're going to say, then there should be something I can pick up. And it's not cheating. When you're with the patient says, oh, it's tender there. Then you go back and say, how light could I have touched that part and told that it was not like the theoretic norm? Yeah?
Can you correlate that tender versus tickle? And those are kind of similar and different.
Yeah, so, in the Stecco's work, they talked about when there's adhesions between the superficial fascia and the deep fascia. So there's not separation from the proprioceptive or internal nervous system and the external sensory nervous system, then it can be, then this extra sensation, that flooding of the nervous system with both nervous systems firing at once, can be pain, it can be ticklish, can be hypersensitivity. It's going to be some magnified, altered sensation. It doesn't have to be pain. It can be ticklish. Because again, the two nervous systems are firing at once, and the nervous system doesn't quite know what to make out of it. Okay? Okay, so pair up. Do it on the person's arm first.